Welcome, everyone. Good morning to everyone joining us from the Caribbean, and good afternoon to those joining us from Europe and from around the world. Welcome, and thank you very much for being with us today. My name is Carolina Vega. I have been supporting a science officer for the Caribbean in the coordination of the People Center Research and Innovation Project in the Caribbean. This is a program led by ICARS and the International Development Research Center, IDRC, from Canada. And this initiative is funded by the UK Department of Health and Social Care from Fleming Fund as part of the UK international development. I think we can already start. We have 40
There
people
seems to be
now.
an issue with the sound, Carolina. We're hearing, apparently people are hearing us double.
Ah,
So maybe we can fix that first.
okay. Let me see. This is very weird. Hello, can you hear me? Okay, there's some people saying that it's clear from their side, so I think majority seems that for the majority it is fine.
Okay.
Okay, okay. So uh, moving forward from the technical issues, and before we begin, please note that today's session will be recorded. If you have any concerns about this, please let us know through the chat. Participants will be remain muted during the presentations so that the recording will be primarily captured. Um, the speakers and the slides. If you would prefer not to participate in a recorded session, you are of course free to leave. Today's webinar focuses on the design and implementation quality improvement for antimicrobial stewardship and infection prevention and control in the Caribbean. Do we keep having technical issues? I see messages popping up still.
No, it's okay. Keep going.
Okay. Okay. So I was saying that we will hear directly from hospital teams from St Lucia, Haiti, and Jamaica about how they identify challenges in their own settings, use local data, and develop quality improvement in initiatives through the Drive-AMS model. Um, Regarding the Drive-AMS Caribbean program, this was one of the components of the project and has been delivered in collaboration with the University of West Indies and Radboud UMC. The program supports hospital teams to identify problems in their own clinical setting, understand the behavior and wider factors influencing practice, and design interventions that are both evidence-informed and visible within their context. So, before turning to today's presentation, I would like to take some time to recognize the main people who have contributed to this program. A very big thank to the University of West Indies, particularly to Dr. Sandeep Maharaj, the director of the School of Pharmacy, to Jeroen and the wider team of Radboud UMC for their expertise, their guidance, and continued engagement for delivering the program and supporting the participating teams. Very important for us at ICARS to recognize the hospital teams from all 10 participating Caribbean countries and territories. Their commitment, engagement, and willingness to work through the challenges and their own setting have been at the heart, really, of this program. And a special recognition goes to the 3 countries that today are sharing not only their work and progress, but also as well the learnings that they have gained during along the way. I would like to also to recognize the ICARS team and everyone who has contributed behind the scenes. A very special thank you to Anik, who is here. She has been closely involved in driving this work forward, and to Chloe for supporting today's webinar and all the communications around it. We will turning to our program now. Ramya Saravanakumar from the University of West Indies will begin by introducing the structure and implementation of Drive-AMS in the Caribbean. We will then hear from Renola Maxius Leon about her team's work to optimize antibiotic use for surgical prophylaxis in St Lucia. Then we will follow with Florencine about quality improvement in infection prevention and control in Haiti and Tertiary Hospital, and from Lydia Miles about antimicrobial use and the timely switch from intravenous to oral antibiotic for patients with community-acquired pneumonia in Jamaica. So with that said, although these projects address different clinical challenges, they share some important questions. How do we move from identifying problems to changing practice? How can local data support the process? And how can improvement become locally owned and sustained over time? Following the presentations, we will have time for questions. Please feel free to submit your questions through the chat, and we will bring as many as possible to the discussion. With that, it's my pleasure to invite Ramya Saravanakumar to begin. Ramya, over to you.
Yeah, thank you, Carolina. So I'll share my screen now. Can someone confirm that you all see my screen?
We can see it, not in presentation mode though. Now it's in presentation mode.
Yes, yeah. So good day, everyone. My name is Ramya Saravanakumar from the University of West Indies, Trinidad and Tobago. I'm a project assistant for the Drive-AMS Caribbean project, and today I'm going to talk about how we structured and implemented Drive-AMS in Caribbean. So first, I will briefly introduce the program. So Drive-AMS is an antimicrobial stewardship implementation and capacity building program, which was originally developed by Radboud UMC in the Netherlands. The main objective of the program is to improve antimicrobial use. So through an effective implementation of antimicrobial stewardship interventions. So when we reduce inappropriate antimicrobial use, we can prevent the development of antimicrobial resistance. And not only that, Drive-AMS focus on infection prevention control practices as well. So when we improve infection prevention practice, ultimately we can improve patient outcomes as well by preventing infection. Then one more important component of this Drive-AMS is capacity building. So Drive-AMS program provide training to healthcare professionals in implementation science and behavior change, because these factors are essential for successful AMS and IPC implementation. And not only that, one important thing is it provide training to healthcare professionals on taking measurements. That is, measurements is particularly important because when we measure antimicrobial use and other related practice, we can better understand the current situation before any intervention. And not only that, measurements will also be helpful to determine after intervention, to determine does this intervention caused any improvement. So we can determine that as well. So how we approach this program. So this is basically data driven. So all our intervention is based on the measurement, not based on assumption. So we form a hospital team. So they are the main core. They are the central part of the project. And we do stepwise approach. so that hospital teams can gradually build their activities upon that. Okay, so then we do interactive courses. So this program was delivered through masterclass courses. These are all not only lecture-based courses. We also do more interactive sessions, and we conduct workshops so that the teams can understand their challenges in a better way. Then we start small. So we all know our healthcare settings have many challenges. So instead of trying everything at once, we start small. We identify a specific problem in their healthcare settings that needs immediate attention and improvement. And not only that, we also do follow-up sessions, that we conduct follow-up seminars, and we contact with the teams. So in case if they need any support and mentorship, we provide whenever and wherever it's necessary. So how we structure the Drive-AMS in Caribbean. So this program focused both on AMS and IPC. The duration of the program is for 18 months. So during this time period, we conducted 2 masterclass courses. Okay? So I would like to mention here that Drive-AMS introduced for the first time, they introduced 2 masterclass program here in the Caribbean. And we do follow webinars, so to monitor the progress of the teams, and in case if they need any support, we provide the support and guidance as well. So ICARS are the organizers of this whole program, and as I said before, the program is developed by Radboud UNC. And we delivered this program here in the Caribbean in collaboration with University of the West Indies. And the whole program was supported by Fleming Fund, through Fleming Fund by UK International Development as a part of the People-Centered Caribbean AMR Research and Innovation Project. So who are all participated in this program? So we targeted ODA eligible countries. So under that, we had 10 countries, like they are Belize, Dominica, Grenada, Guyana, Haiti, Jamaica, Montserrat, Suriname, St Lucia, St Vincent, and Grenadines. So from these countries, so from each country, we formed a multidisciplinary team with the help of their Ministry of Health. So we identified suitable participants and we formed a team. So when I say multidisciplinary team, the team contains not only physicians, but also it consists of microbiologists, lab technicians, pharmacists, IPC officers, and nurses as well. So each team approximately contains minimum 2 to maximum 4 persons. And the whole program was delivered by our wonderful faculty members. So we have international team, regional team. From the international team, we have our course lead, Prof. Shoutan, and Dr. Giacomo, Dr. Nathan, Dr. Ines, and Dr. Enes, and behavioral scientist, Dr. Watson and Miss Anna. And from the regional team, we have Dr. Nagisar, Dr. Satish Janki from the University of the West Indies, St. Augustine campus, and Dr. Makita from the Barbados campus, and Dr. Lydia from Mona campus. And not only the international and the regional faculty, we also received expert support from SPICE registry as well. So this is how we structured the Caribbean project. So having said that, how we structured the program, now we move on to implementation. As I said before, for the first time here in Caribbean, Drive-AMS introduced 2 masterclass courses, the first masterclass and the second masterclass. First masterclass mainly focused on identifying the main problem and provide training for the measurements. Whereas the second masterclass mainly focused on behavioral changes and analyzing the determinants. So we conduct our first masterclass course in Trinidad and Tobago. So this was the 3 days course, took place from 17th to 19th June 2025. So for this first masterclass, we had 26 participants from 7 countries. They participated in person, and participants from Haiti and Grenada team, they participated virtually. And one interesting thing here is more than 50 members. So they are all non-Drive-AMS participants. They participated virtually throughout the course, through this 3 days course. So main focus of the first masterclass was the problem identification. So before we start our first masterclass, we reached out to participants, and we requested participants to identify the main issue that is related to their healthcare settings. It could be AMS or IPC. So they identified the main issue, and during our first day of the masterclass, they presented their problems. So after careful evaluation and discussion with the faculty members, they identified a more specific and important problem that needs improvement. So not only that, during this masterclass course, participants were introduced to point prevalence survey. So as I said before, measurement is an important factor. So they learned about how to measure antimicrobial use and other related practices using point prevalence survey. So at the end of the first masterclass, each team developed a structured approaches to their specific AMS and IPC challenges, and they developed a measurement plan as well. So after the masterclass, they went back home, and we had a break between our first and second masterclass. We had around 6 months break. So during that, we conducted our first follow-up webinar on 14th November 2025 to monitor the progress of the team. So during that webinar, 7 countries presented their ongoing work. And during this interval between our first and second masterclass course, we asked the participants to attend webinars conducted by global PPS platform so that they will learn more about how to conduct PPS in their healthcare settings. So we encouraged participants to register their healthcare settings in the global PPS platform as well. So during this period, they learned how to do the PPS measurement. So they implemented the measurement plan. So before they come to second masterclass, they had their PPS measurements in their hand. So then after 6 months break, we conducted our second masterclass course, again here in Trinidad and Tobago, which was also a 3 days course, took place from 25th to 27th February. So during this masterclass, 28 participants from 9 countries participated in person, and Montserrat team participated virtually. The main focus of this second masterclass is behavior change and assessing barriers and facilitators that are related to antimicrobial use and IPC practices. So at the end of the course, each team developed their interventional plans and re-evaluation strategies for the next 10 months. So the plan is they are going to implement these strategies in their healthcare settings. So these are the list of 10 countries and their corresponding projects. Today, after my presentation, we are going to see 3 countries regarding about their project and their progress. So after the second masterclass, we conducted our second follow-up webinar on 21st May 2026. So during this webinar, 3 teams presented their progress. And during this period, from the SPICE registry, we extended support to Haiti and Suriname team. So in future, our next steps will be, we are planning to conduct a follow-up webinar that is going to be our 3rd follow-up webinar on October 2026. And each team has to present their final reports on December 2026. So that is our future plan. So at the end of our first and second masterclass, we asked our participants to evaluate our course content and course structure, everything. So we received a good response, and the response rate was 62.5%. So among all the participants, 85% percentage of the participants indicated that the course was extremely helpful for their professional activity. And 95% of the participants mentioned that the course has very much fulfilled their educational goals and expected learning outcomes. So at the end, the overall rating for the course was 9.05 out of 10. Yes. So at this point, what we can say is, under this Caribbean project, Drive-AMS Caribbean project, countries have moved from capacity building and identifying their major issues towards implementation of their interventional strategies. So that is the current situation, and we are looking forward to see the final reports and the impact of their interventions. So before I conclude, I take this opportunity to thank ICARS, Rodboud UMC, and UV for their support and collaboration in making this project happening in the Caribbean. And thank you all. Thanks for your time and listening. Yeah.
Thank you very much, Ramya, for the presentation. Please feel free to drop any questions on the chat. And with this, we will now follow with experience in St Lucia. Renola, over to you.
Morning, everybody. Thank you so much, Carolina. I'm just going to go ahead and share my screen. Okay, so good morning again, everyone, and thank you for the opportunity to share on our project. It focuses on optimizing antibiotic use for surgical prophylaxis. We chose to do an antimicrobial stewardship initiative in St. Lucia. And this is our team. To the left, we have Mr. Luther Ugis, who's a medical technologist. Ms. Janice Albert is next. She's our infection prevention and control nurse. And then we have Dr. Christiana Nathaniel, our lead internist, followed by yours truly. I oversee pharmacy services. So this is the core of our antimicrobial stewardship committee. And this is a quick look at our hospital. It's the OKEU Hospital in St. Lucia. It's one of 3 facilities under the Millennium Heights Medical Complex, a 120-bed hospital, our main secondary care facility in the public health sector. We've had an antimicrobial stewardship program in effect documented since about 2009 with active infection prevention and control procedures, quality control mechanisms. We do have antimicrobial guidelines, which includes the pharmacy antibiotic review sheets. We've been trying to do an antibiogram yearly, and we're thankful that we were able to complete one for 2025. Most recently, we've expanded our antimicrobial stewardship committee to include some new consultants. We're very passionate about the work as well. We've done our best to also develop a framework. We have an antimicrobial stewardship plan, which we did not have before, and we're going to continue to work on the policies that go along with that. In January of this year as well, we had the opportunity to participate in the Global PPS, which was a very interesting process. We got to see what our spread was like in terms of commonly used antibiotics, and of course, how that compares with other countries in the region and further afield. Now, how did we select our problem? In terms of deciding which area to narrow in on, we noted over the past 2 years or so that we had more resistant organisms showing up in our laboratory when the culture and sensitivity tests were done. Some of these organisms were multi-drug resistant. We noted as well that patients were co-managed, so different teams had different recommendations on what should be given. There were some supply chain issues, and then training and education was not done routinely, and particularly not for this subject. But one of the things that led us to this project is that we did an in-house survey in 2025, and we found that the use of antimicrobials was quite high on our surgical units, and that included combination therapy. So that's how we narrowed in on this problem. In order to measure, what we came up with as a target behavior is that all surgeons would prescribe the antibiotics appropriately preoperatively and for no more than 24 hours postoperatively. We decided to conduct a retrospective audit to see what was happening compared to the guidelines. We started that in October of last year, between October and December, over a span of 60 days. And since the hospital now has an internal research ethics committee, we had to seek approval from them. It was a bit of a lengthy process, but we succeeded. And one of the commitments, of course, is to anonymize the data. We developed an audit tool which captured some key demographics and the indicators that we would use to measure in this project. Our aim, of course, was to determine whether we had good compliance or not in terms of 3 parameters: selection of antibiotic, timing of administration, and the duration. Duration of administration was our core measure. The benchmark we were looking for the qualitative indicators was 90% or more compliant. And then we also had 2 quantitative metrics that we captured: DOT, which is days of therapy, and LOT, length of therapy. And of course, the lower those values are, the better. What we would then do with this data is decide what the specific areas for improvement were and work from there. So a quick look at our findings. To the left, most of the cases we got in the audit came from the female surgical unit, which is the red part of the pie chart, and that was followed in yellow by the male surgical unit. In the center, these were some of the surgical procedures that the patients underwent during the audit period. Most of them were total or subtotal hysterectomy, that's in green, 44%. And that would correspond with most of the cases coming from the female surgical unit. Other procedures, some were orthopedic, exploratory, we had cholecystectomy as well. To your right, you'll see the antibiotic usage patterns. Those patterns included a high use of cefuroxime, and then we had combination therapy as well with drugs like metronidazole and cefuroxime. We saw this a lot on the male surgical unit, followed by cefazolin. Interestingly, when we did the global PPS in 2026, we were able to also see similarities between what we found in this project and what was captured in the PPS data. Looking now at our core measure, which is duration compliance. How compliant were the units in terms of duration of therapy? To the left, that gives an overall spread. And overall, the first 2 bars show us that we were not very compliant when it came to the duration of therapy. It was about 43.8% of the time that the duration was 24 hours or less. But in most cases, patients were receiving the prophylaxis for longer than 24 hours. We decided to stratify that on the right so that we could see which unit had the greatest challenge. And in the center at 17%, we can see that the male surgical unit was the location where the compliance was the least, which means that on our male surgical unit, persons were receiving the antibiotics routinely for more than 24 hours, or at least in a greater percentage. When we look at the selection and timing compliance, on the left, selection compliance was overall not very good. I think it was below 20% of the time that the choice of antibiotic was correct. And to our right, timing of administration at 44%, the female surgical unit is where we saw the lowest compliance in terms of giving the antibiotic on time. For our quantitative findings, DOT versus LOT. We did the LOT along with it so that we don't overestimate how frequently or for how long the patient was getting the antibiotics, just so we could compare. So the green bar represents LOT, length of therapy. The blue bars represent DOT, days of therapy. And in the center, in both instances, we would find that the male surgical unit, again, is the location where persons were receiving the antibiotics for an average of 2.7 days. And when it came to the length of therapy, for 2 days, which is beyond the 24-hour requirement. We also had an interesting finding. We call it post-surgical days of therapy, because some persons were immediately transferred or put on oral therapy after the prophylactic period, and there was no gap in between these two regimens. And so that's something we're looking to investigate at another time. But for the purpose of this project, we narrowed in on the key metrics. Duration, we found very low, 43.8%, and lowest on our male surgical unit. Selection was overall also very low at 19%, so we're not selecting the best antibiotic. Timing also was moderate, 50% of the time, but it was lowest on the female surgical unit. And overall, what that led us to as an intervention target is zeroing in on our male surgical unit, because they had the longest duration and days of therapy overall. So that's where we would focus our attention. When we met in February in Trinidad, we were introduced to a very interesting assessment tool. There are so many behavior therapies out there, and if we want to implement a practice that changes behavior, it was important to know how and where we would pull out the strategy to do that. The assessment tool, I must say, the entire team was very pleased with. It allowed us to narrow our interventions to suit the context that we had in St. Lucia. So some of the barriers we found from using the tool was that, one, awareness and accessibility. We have guidelines, but how many people are aware of those guidelines? That led us to the intervention where we want to launch and upload to make it available to persons. Secondly, knowledge about what we're doing versus the recommendation. Even though we've done the audit, many persons, our key stakeholders being the physicians, may not even be aware of how far they've deviated from practice. So we said that we want to engage them a little bit more and present the audit report. For quality assurance, we did note when we conducted this audit that we have standard order checklists in the operating theater, but it does not include anything to do with the antibiotics, neither the timing, the selection of drug, or the duration. So that's one area we're looking to make sure that there's a quality assurance system in place. And if there's uptake in the order set checklist, it would help to improve practice. Monitoring and feedback was the last barrier. If it's not routinely done, then of course, we don't have champions on the ground and we can fall off the wagon as it stands in terms of keeping up with the recommended standard. For the facilitators, team processes, it's not a large hospital, and we have a very good rapport amongst our team members. We have some individuals who are quite passionate already about antimicrobial stewardship. And so we decided to enlist our advocates. They're already on board and they are working. Continuing education as well, which would allow us to update persons continually about AMR, AMS, and routine audit findings. So if we have them consistently engaged, we're looking to maintain practice over time. And then lastly, of course, regulation. If we do have policies that are in place and support at the senior level, then it's easier to enforce and ensure that the practices continue throughout the hospital. So this was our improvement strategy in a Gantt chart format. Phase 1, which was the launch, was between March and July. And I'm happy to say that we've come out of phase 1 already. We've completed the launch, enlisted our advocates. We are now at phase 2 in our project. We've posted the guidelines as of August this year, so they are now accessible across the facility with the help of our IT team members. And so we're now at the stage where we're going to look at the CE system and finalize the policy side of it with our director for clinical services. And then in the last phase, we want to implement the QA and M&E frameworks. Of course, our AMS committee, IT team, administrative team, and director for clinical services are our key actors. And this is just a quick snippet of where we are and what we've been doing from February until now. In the top left, that was our flyer. We had a flyer and program where we launched the activity, which was to update our antimicrobial guidelines and also to make persons aware that it exists. And that went very, very well. We had very good attendance, as you can see on the right, from different levels within the physician pool. So we had a lot of consultants, right down to the interns, persons from other teams, and some members from the senior leadership were also present at this launch. And then to the bottom left, that's just the IT process for accessing the new location in the folder for all locations throughout the complex, so persons know where to find the guidelines now. And that was very important for us because we didn't have that before. And in terms of the significance, antimicrobial resistance has national implications not only for human health, but of course, agriculture, environmental health. A national approach is needed. National awareness is needed. A national framework is needed. We're hoping that what we're doing can feed into the efforts at the national level to establish a robust framework that is sustainable over time. Of course, resources are required to do that. Expertise is required. Funding is required. But one key message we would like to give to other teams who might be interested is to start where you can. And that's what we decided to do, because if we waited for everything to be perfectly in place to do this project, then we would have probably still been waiting. So we've decided to make small changes from our level in the hospital, and we are very pleased with the progress that we've made so far, and we intend to continue working. And with that, I say thank you very much. I'm not sure if we're going to do the questions now or later.
Thank you very much, Renola, for the presentation. And definitely, I think that's a very good advice to start where we can, right? And moving forward from there. The questions will be captured for the end. So
Okay.
please feel free to everyone to post your questions in the chat. We will collect them, and we will for sure circle back to them. With that said, then I will follow with Dr. Florence Sin from Haiti. The floor is yours. Dr. Florence, can you hear us?
Good morning, everyone. I'm about to share my screen
Perfect.
quickly. Can you see it?
We cannot see it yet.
Just a second.
Maybe we can share it from our end, the presentation.
Yeah,
Or
the internet is, yeah, quickly.
do you have it, or I can share it if not?
Oh, you can share it if it might be easier because it's getting, let me try again. Okay. It is slow by my side.
Okay, I will then I can share it now. Give me just 1 second. Okay, can everyone see my screen?
Yeah, we can see it now.
Okay, perfect. So
Thank you, Carolina.
okay, perfect.
Yeah. Good morning, everyone. I am Dr. Florence Sine. I am a pediatrician from Haiti. It is a real pleasure to be and an honor to be participating in this webinar this morning. And I'm especially happy to share our progress with you. Thank you to the team and the Drive-AMS that had trained us for the past 1 year and a half. And thank you to ICARS for the support and the opportunity. And thank you to the team for their trust. Here is the hospital. This is La Paix Hospital, the public hospitals with 230 hospitalization beds and with a big frequentation. And then around, let's say, 21,000 last month. That's a lot. Actually, it is the first hospital in the country with 20 emergency ward and 64 beds in pediatrics. Since the last webinar in May, you can move on to the next one, please. This is our team. Pascal Laura, he's an infectiologist. Christina, a pneumologist. Mr. Inavese, pediatric nurse, and this me. Yes, next slide. So, me. We have been working to raise awareness among hospital administrators in order to establish ourselves as the hospital IMS IPC team. So we on June 10 June 26, we were able to present the program and raise awareness among all department heads and various hospital departments under the leadership of the medical and executive management. We were able to organize a large meeting with all the department meeting with all the department heads of including internal medicine, surgery, nurses, the various department general services, and the laboratory. Representatives from all sectors of the hospital were present, nearly 40 people, to raise awareness across all departments and at the same time facilitate our effort. To ensure a successful implementation, we enlist the service of ICARS, especially the SPICE program, to assist us with the program implementation. It happens the same day in the morning, and that is how we had our first meeting on June 10 as in the morning of the day we were scheduled to meet with all the department heads. We were joined by Ernestine, who served as our facilitator, and to whom we outlined our expectations and future plans. Then on June 13, we held a hand washing demonstration and an awareness session in the pediatric department to improve the habits. There were two training sessions on infection prevention control session IPC organized by the Ministry of Public Health, Western Health Department in late June and early July. Dr. Christina Douillon and Mrs. Vincent participated in this session. Following this training and with the aim of facilitating our awareness raising effort in the hospital, various departments, Dr. Christina Douillon established an IPC focal point committee with the head nurses from all departments in the hospital on July 2026. As a result, they were able to understand how to raise awareness in their respective department and learn how to conduct audit. So as a result as well, we were able to conduct hand washing audit in the various pediatric unit, the emergency room, the maternity ward, and the orthopedic department during the month of May, July, and August. We will soon see the result in the graph. And on July 33, a new group of interns has come to the hospital. Pascal and Christina were invited to speak with them about the hygiene measure they should follow during their internship in the various departments. You can move on, please. So this is what we install in the hospital, but we are working on move on and to implement the materials, like the alcohol and the dual hydroalcoholic, the gel hydroalcoholic, to have an habit as promised by the medical director. So this is where we come from. This slide shows us our initial situation. In January, when we come, we start at 48% of hand hygiene habits. And then, hello? It disappeared. Okay. Yes, we go from 48% in January and drop into 23% in May. This let us implement awareness raising strategy and advocate with hospital management. And so when we start monitoring the hand hygiene in July in pediatric, we realized that we see the number of opportunities for doctors and nurses, 16 for doctors and 23 for nurses. And number of action, 6 for doctors and 10 for nurses. Number of friction print, 1 for doctor and 0 for nurses. That really was worry. We said that something was going on. So we start more motivated and sensibilized. And then in August, we saw that we have a rise for opportunities in hand hygiene, 32 and 80 for nurses and 18 from doctors. And from action, we go from 10 to 19 for nurses and 9 for doctors. And from 0 friction, we go from 0 to 5 and rising to 8 for doctors. And then for lavage, we saw that we raise for the nurses and not that much for doctors. And use of gloves raised in August. So that really aware us, so alert us. So you can move on, please. And we go in the emergency ward. So we go from opportunities, as we can see in July. Some opportunities to the nurse was 16 and 12 doctors. And from action, we go, it was 0 for doctors and 1 for nurses in July. And for friction, 0 at all. And then for lavage, it was really alert. 1 for nurses, 0 for doctors, and use of gloves was rising in July. So after sensibilization, we go in August, and we see that the opportunities rise. They go from 16 to 24 for the nurses, from 12 to 19 for the doctors, and then for action, we go from 1 to 18 for nurses, 0 to 11 for doctors, and for friction, there's a little rising. For the lavage, it's really a rise from 1 to 17. For doctors, from 0 to 9, and for glove, it's really decreased. So the compliance shows that it goes in the emergency ward. For July, it goes from 48% to 57%, 67% in August. And for the pediatrics department, it goes from 41% to 58%. So that shows a little rise for both departments from their habits for the results. So when we go to the slide, we went in 4 departments, and we did an audit in the urgency, in the emergency ward, in the pediatric, in the maternity, and the orthopedic. It shows that the emergency rise to 67, as we show. The pediatric rise to 58, as we show. The maternity has, after the audit, it goes to 8%, and in orthopedic, it goes to 70%. When we do when we made the chart showing 4 department, the compliance in August for the 4 department, the opportunities rise to 280 for the 4 department, and the numbers of action goes to 83 for the 4 department, and the numbers of frictions go to 23, and the number of lavage go to 64, and the use of gloves go to 91. But what shows behind below, it shows that when we analyze and to see the chart and to see if the washing, the hand washing was equivalent to the use of gloves, it didn't show us not that much. It shows that it didn't impact the lavage that goes to 72%, and then it didn't show that the use of gloves were more than the use of lavage. So it tells us that we have to keep continuing and to sensibilize, and then the words, the message, is as passed in between the department, and we have to keep moving on. So the audit result shows that the hand hygiene competencies, if we go from the baseline 29% when we start, and follow up in May, that shows we rise to 48%. So we were worried in July when it dropped to 17%. So when we work, when we look at our work, our sensibilization, and the different audit that we have made in different departments, it shows that in August it's rise again to 32%. So I have to say that when we sensibilize the nurse in the different department, and then we keep continuing the audit. We have to say that there's more water in the different, I don't know, specifically in pediatric in the emergency, but in the other department, sometimes there's lack of water. Those are the points that we notice. So, but we have see that there's a lot of affiche that shows that they have to sensibilize them to how to wash their hands and to improve their method. So our plans is to continue the training and hand hygiene by September, and to make a bigger training, let's say in the hospital, and then all the team will be in charge, and then we will continue the monthly audit to measure our progress and to see how it improve. And I have to say that we have I had talked to the medical director last 2 days ago, and they already bought the alcohol, and then we hope by September to have alcohol in all the department, and that people can use it frequently. We keep continue to sensibilize with all the heads of the different department, and we hope by the end of by the next trimester, be able to generalize the habits in all the hospital. So thank you for your attention. Thank you for your time, and then I am available for question and commentary. Thank you.
Okay. Thank you very much, Dr. Florence. I see there is a hand up. If you would be so kind to post your question in the chat, Naledi, that would be great. Okay, then following this, I would like first to thank you for the attention. It was very important to see the steps you have taken forward in Haiti. And now we will follow to Jamaica. Lydia will be presenting now. The floor is yours, Lydia.
Good morning, everyone. Just checking if everybody's hearing me clearly.
We can hear you very well.
Also, if you can see me.
Yes, we can see you.
Okay, so let's share the screen. Okay. Are you seeing my screen?
Not yet, but I think now we can see it. Not
Okay.
in presentation mode though.
Okay. Okay. Are we good now?
Yes, it's perfect.
Okay, great. All right. So good morning, good afternoon, everyone, wherever you are. It's nice to be here. Nice to see everyone again. So the Jamaican context is a little different. It has been different from the get-go, in that our team is comprised of 4 IPC nurses and myself. We're all from different hospitals at different spectrums of hospital organizations. So I I started the project with ICARS while serving as a senior resident at the University Hospital of the West Indies. And we have 4 IPC nurses, one from the St Anne's Bay Hospital, one from the Cornwall Regional Hospital, Kingston Public Hospital, and the Maypen Hospital, all representing hospitals from the different health regions within Jamaica. That is good, and it has its challenges because my team is not all together in one place. But what it did give us was the opportunity to, when we did the global PPS study, was to get information from all of those hospitals. Well, most of them, we had information from Maypen Hospital and St. Anne's Bay. And recently, Sister Marva Coombs and I, we completed the entire St. Anne's Bay Hospital in doing repeating the PPS. So it's up for validation and review, so we can compare the 2 periods. However, when we went through the masterclass with the Drive-AMS team, we chose a stewardship project, and that was to look at a timely IV oral switch in community-acquired pneumonia at a tertiary facility in Jamaica. So the information for this was coming directly from the University Hospital of the West Indies. So we basically wanted to review antimicrobial use and timely IV oral switch because we found that whether in the community or in hospital, that the most treated infection was from the respiratory tract, and that physicians were more likely to use empiric for more likely to go ahead with their treatment using empiric regimens, and that there was ground to drive resistance. And we wanted to use AMS as a tool to limit resistance by switching from IV to oral in a timely fashion in patients who met a particular criteria. So just for your reminders, those who've never met our team, this was while we were in March when we had our final session in the Drive-AMS. These are the nurses I was mentioning. Okay, so what is antimicrobial stewardship? Basically, is a coordinated event. So we want to give the right antimicrobial at the right time for the right purpose and the right duration. And I must take the time out to say that when we joined the Drive-AMS team, what we recognize is that even though you may have snippets of AMS or antimicrobial stewardship being practiced in hospitals, we did not have dedicated leaders to AMS within our region, within our country, and that posed a problem because you didn't have somebody who was dedicated and have interest in antimicrobial use and duration of use and so on, and this remains an issue to date. So our goal was to optimize clinical cure while minimizing antimicrobial exposure and driving resistance and infections like C. difficile. So how does stewardship help with resistance? Basically, as I stated, you want to, every course of antibiotic, you don't want to have too much of a broad course. You want to make sure the course is as narrow as possible. The duration of treatment is as short as possible, but you'd have achieved cure. And you don't want to add too much selective pressure to the organism so we don't cause a propagation of resistant ones. So what is IV oral switch? So basically, you're converting a patient from intravenous antimicrobial agents to oral antibiotic therapy once a defined clinical criteria has been met. And that clinical criteria could look anything like, for example, under community-acquired pneumonia, the patient is clinically improving. If they were septic, you have resolution of sepsis, and that can be measured clinically as well as using biochemical markers. The patient is hemodynamically stable, afebrile or defervescing within 24 to 48 hours. There, when you look at the biochemical parameters like their white cell count or CRP, that's trending down. They are tolerating oral intake, and this is very important that you have the guts for the patient is working where you can have absorption of the drug before you convert. And there is no deep-seated infection, for example, endocarditis and meningitis, and you're pulling back too early. Why does this matter? So as you can appreciate, if a patient is on prolonged intravenous therapy, they need IV lines. And some of these patients have difficult veins, and so they end up with central lines, and that's a whole ball game by itself. So we want to limit or have fewer IV line complications like phlebitis or infections, bloodstream associated infections with central lines. We want to improve early mobility and discharge. And in that saying, you will have shorter hospital stays and less cost to patient care. So you have lower drug consumption, and it basically helps us not to pull on our nursing staff so much because it would take nursing staff to administer these IV medications. There's less broad spectrum IV exposure, and we have studies have shown comparable outcomes in patients who are eligible for an IV oral switch. So when we looked at the antimicrobial stewardship that we had at the UHWI, we're a 600-bed facility or teaching hospital, right? And we serve patients throughout our country as well as our region. We have an IPC team that comprises of one IPC physician and 4 IPC nurses that basically vet our wards. Throughout the country, when we looked at the country, there was not necessarily an IPC designated physician, but there were always IPC designated nurses. Other teams would have maintained that they would have appreciated more nurses on their teams, but there were no dedicated AMS physicians. So why CAP and why IV to oral switch? So CAP, as I said, is a very common infection. And oftentimes, if it becomes complicated, patients will need IV therapy. However, prolonged IV therapy drives hospital costs, right? And it drives the length of stay of admission and exposes the patients to hospital-acquired infections. So timely IV oral switch is a low-cost effort with high yield in stewardship, as well as high yield in terms of benefits to a hospital. We also noted that when we chose this topic, there were no formal switch policies currently existing. So we were using the IDSA guidelines, but when it came to in-hospital guidelines, we are yet to convert to having our own written guidelines that are enacted and in use. So already techniques that we already have in use, though, include we have a multidisciplinary team that include, we have 2 ID physicians, clinical microbiologists, and we have clinical pharmacists, and we have an IPC team. And the IPC nurses, they do follow through with, or we have a surveillance list. So every day after the read off of our cultures, we have generated this alert list with target organisms, which the nurses take an action through the IPC team to visit the patients to ensure that they're properly sectioned off, to ensure that they're on the appropriate therapy, and the dialogue with microbiology and or ID to ensure that the patients are switched to their appropriate therapy and durations. So we also have front-end restriction in that at the university hospital, physicians are required to get prior authorization before the use of fluoroquinolones, carbapenems, and vancomycin. We also have a very robust microbiology lab where we have culturing of both bacteria and fungus, and we have a very good virology lab as well. And we have, in our chemistry department, we have measurement of our CRP and procalcitonin that is available, as well as MICs and other means of complementing or antimicrobial reports by using this diffusion method routinely for AST. So where our gap really exists is in guidelines and education. And we wanted to have a robust empiric guideline when it came to CAP. So our stewardship issue of interest, is there a lack of timely IV oral switch in the patients with CAP at our facility? So our focus, when we broke it down using the method given to us in our ICARS training, we said, who are the persons of interest? This would have been our physicians and nurses, or physicians because they would review their patients daily, and they would be aware of, the changing clinical parameters, as well as how the patient is improving, and to be able to switch the patient appropriately. When would they do this assessment? Within 48 to 72 hours of IV therapy. Where would this happen? Our focus was mainly on the general adult medical ward. And the target was to basically have, as we said, our timely switch in patients who were eligible, who had a community-acquired pneumonia. So how we measured our problem, basically, we did a baseline study. And I must say at this point, thanks to Doctors Job and Miller, who are junior residents who helped me to collect this information. So we measured the problem by looking at 106 patients who were diagnosed with pneumonia through our records department. We got all patients listed with pneumonia. Then we went ahead and looked and categorized those who were community-acquired, hospital-acquired, meaning and ventilator-associated. Then we looked at those who were eligible for a switch based on the parameters that we had. So in our pathway that we developed, the patient had to be admitted to a medical ward. They had to be diagnosed with a community-acquired pneumonia. They would have had started IV antibiotics, and the respiratory cultures, sputum or bronchoalveolar lavage would have been collected maybe. So some patients had it, some didn't. And at 48 hours, we would have seen biochemical improvement. So we had starting SpO2 at 72 hours. We, at room air, we had starting body temperatures at 72 hours, and we had starting white blood cell count at 72 hours. And then we would have looked at the complete clinical picture of the patient to determine, was this patient eligible for a switch, yes or no? So our quality indicators, as we would have highlighted, would have included portions of CAP patients on IV therapy within 40 to 72 hours, if they had a respiratory culture taken, and our target, we wanted to note that there was 95% timely switch and compliance. So our numerator was basically community-acquired pneumonia patients, switch to oral therapy at 48 to 72 hours, divided by all eligible community-acquired pneumonia patients times 100. So in any change environment, when you want to have change, there are barriers and facilitators. And during our training in Trinidad, they helped us to determine some of these barriers and facilitators to, having change in clinical practice. Some of the barriers that we would have come upon would include to have this level of change, you would have to have higher scrutiny of the patients at the bedside and interaction, and we felt like it would possibly disrupt the established workflow, and it could serve as a barrier. Other barriers included limited insight into how current practices affects duration of therapy. So if there were like missed antibiotic doses, drugs that were not available and so on, then that could, how it affects clinical therapy and the duration of therapy could be a barrier. There's also physician fear that early oral switch could reverse your gains. And so out of fear that IV therapy could have been maintained inappropriately. There's also patient barrier, that patients believe that a shorter duration is less safe. And so they may also ask for a longer IV therapy. And we said another barrier is timely switch is basically a low organizational priority. It takes some effort to get organizations to buy in, meaning the heads to buy into the need for all this AMS scrutiny, to provide the necessary tools and teams to work with to ensure that we are practicing appropriately. Facilitators, however, include performing a timely switch. It basically requires minimal effort. Recommendations are consistent with international guidelines. People are more likely to buy in. If staff are motivated to shorten therapy and reduce lengths of stay in hospitals like ours in the Caribbean, where there's constant overcrowding, if we can limit IV therapy and discharge appropriately, however, in a shorter time frame, this will help to free up spacing for bedding and allow patients to be treated in more comfortably. So our intervention would include, and you'll see further down, I had coined a written empiric therapy guideline consistent with international standard. We wanted to have prescriber education. So we aim to have a grand round teaching, especially where medicine grand rounds are kept, and ward level reminders on timely switch criteria. So the protocol that has been developed, we hope to work with our IT team to have it uploaded where physicians are reminded of timely switch for patients with CAP. And this could be based on a indicator system where once information goes in, it could also involve the use of AI. So the patients are tagged or flagged for appropriate review for IV oral switch based on the criteria being placed in a hospital information system. So we wanted to also have a repeat of our audit to have track or timely switch compliance after we've had our prescriber education, and have some feedback to see if the teams have complied. So the stewardship opportunity exists when we looked at the information. Some of the patients were not eligible for switch. They had other complications like a pneumonic effusions. But there were patients who were eligible for switch that were not switched. So basically 1 in 4 patients who were eligible for switching were not done. And so we had prolonged IV therapy. What we found is that in the eligibility cohort, those patients were on IV therapy for an average of 7 days, who could have stopped IV therapy at 3 days. We also looked at the days of therapy for patients. We found that even from our PPS, we had a lot of drug use in the watch group. So the WHO classification of, antimicrobial use, we were using a lot of drugs from our watch group for our pneumonias. So we had a high use of Zosyn for those patients and Ceftriaxone. What we did not see was that even though drugs like doxycycline are recommended for the use of for use in the treatment of community-acquired pneumonia, there was not even one patient who we had use of doxycycline for. So basically, the outcomes and the note on the data, we looked at all the patients who would have had a diagnosis for community-acquired pneumonia, and more than 50% of those patients would have been discharged. However, we had 18 of those patients who would have deceased based on complications from their illness. And so, as we said, that not everyone was eligible for discharge, as some of these patients were seriously ill. So this is just a look back at antimicrobial use based on the PPS that we conducted. And as I was explaining, in the 3 categories, access, watch, and reserve, between St Anne's Bay Hospital and the UHWI, we found that at the St Anne's Bay Hospital, for example, we had this is a secondary hospital in the northern region of our country. Majority of our patients were on drugs within the watch group of drugs. And at the UHWI, it was the same thing. 80% of the patients were on drugs that were under the watch list. And we really wondered how we could get a higher use of antimicrobials that were in the access group, if there was a way in which we could do so, and especially among patients who had pneumonia. And we want to extend this study to more hospitals throughout the country, so that we can help to inform our national action plan on antimicrobial use. So what the audit tells us is that oral step down is achievable in some patients. It was achieved in most patients. General awareness exists among our physicians, but early timely conversion occurred in only a minority. Some were switched at 7 days, so people completed the IV therapy before switching. Broad spectrum IV agents account for most antibiotic days, so early switching would meaningfully cut antimicrobial exposure. In conclusion, a structured, locally owned IV to oral switch pathway is desired, and this can be anchored in our CAP treatment guidelines, which I will show you shortly. So here it is. I have used the IDSA guideline to create a 2-page summary, basically, of what our community-acquired pneumonia protocol could look like, duration of therapy, how to assess severity, and so on, and to help to guide our physicians in when to switch. So if we had more coining of these one-pagers that was easily accessible on computers in our hospital information systems, then it would help to inform our physicians, but it is accessible so more people may use it and may consider their patients for switch in a more timely manner. We hope to pilot the policy and then to re-audit in a timely manner. So our recommendations and next step, as we said, to adopt the written policy that we have here, to conduct the audits, to run a follow-up study on behavior change in IV oral switch post adjustment, and to appoint, we really hope for the appointment of a formal AMS lead and with defined accountability throughout our hospitals, and especially at our tertiary hospital. Maybe that can be the where change begins. I know personally that we have started to try to have this in place. It has not yet been done, but we are on the right road. Since our AMS training and so on, we have had coining of what an AMS physician should look like and how it would benefit our facility. And we hope to engage our clinical pharmacists in calculating our DOTs and DDDs more consistently. And as I said, we have completed a second survey of the St. Bay Hospital, which is up for validation. I have not been able to do one for the UHWIs yet. And then we can look across facilities to see if there's any improvement in our antimicrobial use. This was our intervention plan. So we have achieved some of it. However, some of it, I must confess, has been hampered by some of the dates were really in our examination period between April and July, as well as there has to be continuity with other members of our team at the UHWI as we pass on this baseline study to continue. So we have had discussions with, like, for example, my HOD, we've had our coining of what AMS physician should look like. We are having discussions currently with our head of our hospital so we can have AMS more integrated into our daily operations. And then we hope to, through our IPC nurses and our residents, to see to the full initiative of our CAP guidelines and the review in due season. Thank you.
Thank you, Lydia.
You're welcome.
This was a great presentation, and I think it gives a very good overview of how much work you have done in Jamaica. So with this presentation, I will follow up with the questions. First, I have a couple of questions for Renola. The first one would be, was there any specific clinical issues among patients on the Mayo Surgical Unit that require use of prophylactic beyond the 24 hours? As we are having a lot of questions, I will ask to please your answers to be as precise as possible, and same goes with the questions. Over to you, Renola.
Okay, could you read the question again for me, please, Carolina?
If there was there any specific clinical issues among patients on the male surgical unit that required use of prophylactic beyond the 24 hours?
No, not based on what we would have noted, because during the audit, we went through each file in detail. We actually went section by section, day by day, reading the physician updates, nursing notes, looking at all of the clinical microbiological data that we got. And there was no indication to continue beyond. So we're thinking that it was just a norm that became the standard, but it's of course not concurrent with what guidelines would recommend.
Thank you. And then the second question, it's from Monique, and thank you for the inspiring talk. She's wondering whether you are starting to think or maybe already implementing other quality improvement studies for AMS and IPC now that you have gained experience through the Drive-AMS.
Oh, yes. Actually, what we did is piggyback on what we're doing for surgical prophylaxis, and we took the opportunity to look at other infectious syndromes that are common in the hospital, and we've updated the guidelines for those as well. So since we've launched all of them together, we can now do an audit and see whether or not it's actually improving practice, and then we can take it from there. So since we gathered physicians together, we didn't want them to get excited about just one thing, which is surgical prophylaxis. We added in a few other common infections there. So we intend to take everybody along for a very great ride, and we have great support so far. We're happy about that.
Very nice to hear, and wishing you really the best in those steps forward. So we have another question. Do the teams have any plans to publish either academically or elsewhere their projects and evaluations so they can serve as evidence and examples to other AMS committees or quality improvement teams in hospitals globally of approaches that could be tried elsewhere as well? I think this is a question that all three teams could actually answer. Maybe, yeah, Brenola, you're there, so if you want to start
Right.
with
So
it.
for us, we have already mentioned in part to the chair of our research ethics committee some of the work that we're doing. And it would be great to publish. When I saw that question, I said, that is a very excellent idea. I'm not sure if ICARS or any of the others teams that work along with you would look to putting out maybe a briefing or some sort of publication where we can then put something together that fits within that larger document. That might be great, as opposed to trying to do it individually at the hospital level.
Thank you, Brenola. Yes, actually, as ICARS, we are planning in some publications that are on the way. This is more in other activities, the baseline studies that we're doing. But yes, definitely from this project, we will come up with some research from the region, which we are very happy about. I won't take more. So, Florence, if you want to say something, Dr. Florence, if you would like to say something about this.
Yes. Can you repeat again the question?
So this is about the plans of publishing, but as well, if there is any policies, guidelines that you're having internally or nationally coming out from the work that you have done and that you can share how this will be moving forward for you, then yeah, please share it.
No, not at all. No problem to publishing. So we don't have, I don't know if there's any policy, but not particularly, not by my side. So for the work, for the hospital, I think that I might see with the directors because it concerns the hospital first. But I'm pretty sure that they are aware that we are part of this program and they know that it's already public. So I don't think they would mind that it might be shared. Yes, it might be share everywhere. So yeah, there's no problem. I don't think so.
Okay, I think a little bit goes in the same line for you, Lydia, right?
Pardon me?
Sorry, Carolina, can you ask a question again?
Yes. So if there is any plans of publishing part of the work, or if from this experience, if internally is there any policies or that are coming up and connected to the work that you have done internally?
Okay, thank you. Well, yes. So one of the junior resident who worked with me while I was a senior resident at the UHWI, she is very interested, like myself, in AMS and IPC work. So we plan to basically formalize this project to have continuity, to have her do it as her final graduate project. So we'd extend the IV oral switch, try to get space within the medicine grand rounds, especially during pulmonology time, to present to all of our medicine physicians. Then we would do our post presentation audit within like a 3-month period. And she would basically, so we're going to work together to make it an official, what we call a DM project, which is like your project that you would do on your final exit from your microbiology, your postgraduate study. So that's the route that I have in mind currently, but definitely want to publish the information.
Very good to hear, and very encouraging. Yes, thank you for your answers. I will follow now with a question directly to Dr. Florence. It says, congratulations in having implemented this in your hospital. Have you been able to understand through conversations with the staff what the reasons are that the staff are not complying with HH moments? Is it only related to the absence of water, soap, or gel, or are there other possible reasons?
As I can say that now that we have talked to all the head department, and now that we have talked to the nurse, the head of the nurse, they are more sensibilized. And as the audit shows that when we go and look after them, they are more mobilized to wash their hands. The problem is the lack of water in certain departments. Sometimes they might not have water, but with the talk with the director, the medical director, and they are aware of that, and they really want to improve in the to go from the water and to go to the the gel hydroalcoholic. So they already bought the alcohol. And as he told me 2 days ago, the alcohol is already there. They are planning to put them on bottles. And by September, they might be available in all the department. This is a big step for us. So they are planning to go to the gel hydroalcoholic, but they don't have all the materials yet, but they will start with the alcohol. So the feedback is people are aware, but the change of habits is the big challenge, because in some department they are aware of they have to really wash their hands as we saw, but sometimes the use of gloves that we saw in the last few months decrease a little bit. So we think that most of the time when they go to wash their hands and there's no water, this is the one of the reason. And as mentioned in the last webinar, really, as there's not the possibility, the water. Actually, it's really hot in Haiti, and the water is really, really hot. So instead of washing their hands, they might put the gloves. And if we talk about it to the medical director, and this is one of the point that not encourage, to let him go to buy the alcohol. Let it say this way. So yes, it is a challenge, but we are really concerned about the difficulty. But we are really working on that, and and to see how to improve, to make them change their habit. But it's tough. It's tough.
Okay, so you're cutting a little bit, but thank you so much for your answer. I think we have a very interesting question as well from Anna Thirion. It's for Florence as well. So she's asking, what is involved in local production of hand sanitizers? Is there something other settings with procurement difficulties could also try?
I think that we already have the alcohol, but those the other ingredient that needs to be found, it's because they can't find it yet in the on the market. Let's say this way.
Uh-huh.
So I think that they are, and then I think that the hospital is trying to find a place. The pharmacist, it's really. Let's say he is really aware that he wanted to be part of it, and I think that the director needs to find a place to fabricate to do it, so and to have it available for the whole hospital. So to start, he proposed that we will start with the alcohol, because what we did, I know they say that it is expensive, but we had reserve some chlorhexidine, so we start with the chlorhexidine. But after a talk, and after talking to you, and we saw that using the chlorhexidine, even though we have it, it's really like a lack of wasting of materials, so we leave it for the operation room, and then so we move to the alcohol. So we just need the other materials to just put the gel hydroalcoholic disposable.
Perfect. Thank you very much for your answers, Florence. I will try to capture as much as I can because I see we are coming short with questions. So I will follow up with the next one. There is a question from Botswana, Florence. I think you already responded part of it, saying that you buy the alcohol. But if you could please maybe talk a little bit about the advice on how your team is navigating sustainability and continued provision of HH consumables and training after the donor rounds are completed.
So okay, what we are doing, we had meeting oftenly, and we talk around how the progress in, even though we have the audit periodically. So we share our progress, and we see what are the problem, what are the challenges, what are the difficulties, and how to counter them. And then from there, this is how we saw that we have to improve it to the whole department. So the idea was to improve the head of nurses of each department, and then to show them how to do the audit. And then from there, so we continue to sensibilize them, and to see what are the barriers, how to counter them, and how to have the result. So this is a concern for us, and then we keep continue to see how to improve. And we have to say that we are really lucky that finally the head of the administration of the hospital, they are really concerned about what we are doing and how to accompany us. So even when the new intern, they joined the hospital 2 weeks ago, they invite us to come and to tell them this is the new policy of the hospital. They have to respect it, and they have to embrace the washing hands, to not acting over how do you say to
Very
go to
good.
the same way that we are going, because they are new, because we already talked to all the section of the hospital, even the personal of take it care, even the security, even all the staff are now aware of they have to wash their hands. And I was so surprised, and really happily surprised, let's say this way, in the entries of the hospital. I saw patient come in, and I saw the security guard tell them wash their hands before going through the big barrier. It was I see it by myself, and it was a bit. It's coming slowly but surely to go with this habit. So we are waiting for the next step to see how the alcohol will go with all of it, all of the people. So we will see with the audit how it shows, because it is a way to control the lack of water.
Okay, thank you very much.
Thank you.
I would like just to have another good question. And this is for the three people presenting. Maybe we can start with you, Renola, and it's about which barriers do you think will be the most difficult to overcome to sustain good practice, and why? And congratulations for the great job done so far. This is from Gloria, that you all know from ICARS, that she started with the project. So over to you, Renola. Your thoughts about it. We are very short on time, so if you can be very precise on your answer, thank you.
Okay, sustainability, you said, was the question. That word wasn't quite
Yes.
clear.
What do you think it will be the most difficult to overcome to sustain good practice, and why?
Oh, okay. So for our side, what would be difficult to overcome is the old habits, old behaviors. Persons may end up getting stuck in a rut and get accustomed to what they've fallen into as a practice over the years. So maintaining new practice, establishing it in the first instance, making sure it's robust, and then doing our best as a team on the antimicrobial stewardship side to try to maintain practice over time. I think that once the wheels start turning and we have our advocates on the ground working along with us, we should be able to get persons trekking along fine, and hopefully future teams continue to do the same thing.
Thank you, Renola.
Yeah.
Lydia, if you would like to follow up as well with your answer.
Okay. Okay, so our barriers may be twofold. One of the greatest barrier I have found in the Jamaican context is to get administrative and leadership buy-in. And so that's a huge hurdle that I think we have to overcome. Maybe one of the ways is to actually have published data, and then people start paying more attention to the various areas, but that is still an issue in terms of getting the information into the right ears. When it comes to the second one is to create the opportunities to re-educate our physicians. I think once we have those opportunities to educate, we may have more behavior change in terms of timely IV oral switch. As I said, our society is quickly changing into a more litigious one. Traditionally, we are not. And so people practice sometimes out of fear. So fear informs practice sometimes. So people don't want to pull back too early and then at the risk of having a patient at risk of developing complications related to their pneumonia. So I believe that once people can practice with confidence and there's written documentation that guides hospital policy, so that also goes to having a published guidelines for our hospitals. So physicians can practice with more confidence when they have something written that they can stand by to say this is our stance as a hospital, and then we will have some amount of behavior change. So hopefully we can get it into the right ears, and to also get these policies integrated into our information systems. Sorry. So we have that conversion from written dockets, or what we call patient files now, into a computer-based file system. So if we can get our guidelines into those systems, then it will help to inform.
Thank you. Thank you very much. And I think, Dr. Florence, if you can have a very short and precise answer to this.
For me, my internet is really gone up and down. Can you repeat it?
Yes, of course. And with this question, we will be closing the webinar. Sorry that we are running a little bit farther, but the discussion is very rich. The question is, which barrier do you think will be the most difficult to overcome to sustain good practice, and why?
Oh, thank you for the question. I think that the challenge are to improve the habits, I think, and then to have the material available. So now they are mobilized to buy it, but they will have to continue buying it. So it has to go through the directors and to the administration to make it available, and from there, so to find a way to let the people change their habits. I think this is the big challenges. So we are thinking about that, not thinking, but we already talked a little bit about that to find different ways. Let's say like on the TV, like to say some having some band pass to do the education, and having not only having the posters, but we plan to use the nurses head of each department to aware, but we don't have enough record to see how it's gonna be, but we already talk about this plan, and we will see how to conturn and those habits we need to move on to
Thank
change.
you. Thank you very much for this. It seems, and I know that for all the projects you have made amazing steps forward, which are following up, and we're really first congratulating everybody who is involved in the process in each of the hospitals, and thank you for the engagement. With this, I think that we have some other questions that we will collect and circle around. I'm sorry that we are not able to address all of them during this webinar, but thank you for the engagement and for the rich discussion. Have a very good afternoon. We will record. We have recorded this session, and we will be sharing it as well with you.
Thank you.
Thank you, everyone.
Thank you.
Thank you.
Okay.
Thank you so much.
Thank you. Goodbye and good morning, good afternoon.